Office of Head Start on the new Head Start program performance standards. We're thrilled that you're on today. We know many of you were on our previous webinar, and the registration numbers are really, really strong, so we know there's really great interest in what the Office of Head Start has to share on these new performance standards. So we know that there was homework today, so I hope that you did your pre-reading. We do have Q&A options. If you went to in the question and answer window on your right-hand side of your screen, please feel free to type in questions. We will pause periodically to let questions be answered. We'll keep an eye on the window as we go through. Whatever we don't get through today, we will do our best to get you back out answers if we don't end up getting to everything today. I know in the last webinar there was a lot of good Q&A, which is critically important. Yeah, I think it makes for a more valuable training and presentation when there can be dialogue back and forth. We are recording today's webinar, so you will get copies of the slides, I believe. No, the presentation. Okay, no, just the recording. Sorry, just the recording is what you're beginning. So we are joined today by a team from the Office of Head Start, led by Ann Linehan, the Deputy Director at the Office of Head Start, who has joined us at many partnership events and has been a great partner in this work. So with that, Ann, I'm going to turn it over to you to introduce your team, and we will get rolling.
Okay. Well, I have three of my best buds here today, so I'm really happy. And this is an opportunity for us to spend some time together, which is terrific. So to my far left is Marco Beltran, and he is our lead in everything related to health services, and that covers a wide spectrum. To my immediate left, Amanda Bryans, and many of you probably recognize Amanda. I think you've been at Head Start how many years?
I think I'm going on 28 years.
28 years. And Amanda now currently leads up our research, analysis, and communications, but is also everything education today. And to my immediate right is Kirsten Beigel, and Kirsten, as many know, has been the guru of anything related to family engagement and community partnership for how many years?
10.
10, a long time. So we know that last time, as Denise said, we ran a little bit, it was a little bit tight at the end to get to the questions. My colleagues have looked at your questions, and to the extent we can, we're going to wrap them in the presentations. I also want to put a plug in for the third Wednesday of each month. We are having grantee webinars. We have gotten a lot of questions about HR. So we are going to devote the entire webinar on, I think it's the third Wednesday in November. I want to say it's the 16th or 17th, if someone can figure that out. We are going to devote it to human resources. So we're going to be a little bit light on human resources today. We'll probably touch it in a couple of places, but please join us for the grantee webinar. And again, Denise, thank you for inviting us. Our relationships with community action programs is important. They represent a huge number of grantees serving our most vulnerable kids, and we know when it's done right, it's a fabulous organization to provide Head Start and early Head Start, and partnerships too. We're going to start out with Marco. Marco, I'm just going to hand it over to you and get us on our way.
You get started? Perfect. All right, next slide. So I always like to start off with just kind of thinking about health as a foundation for school readiness. I feel strongly that it's very important that we do this from the very beginning. So starting off, children with access to ongoing medical and dental care to participate in programs that support nutrition and family education experience fewer developmental delays and chronic illnesses. We also know that children who are fully immunized and have access to healthy and safe environments, they're less likely to be sick or injured, and therefore have higher attendance rates, which are important for school success. When you screen children as part of your EPSET requirements and make referrals for evaluations if needed, you increase the likelihood that children will receive support from early intervention services so that they can fully be engaged in learning. And then finally, the comprehensive health services coordinated through Head Start and Early Head Start programs include everything from Head Start meal services to accommodations for children with chronic illnesses, and offer children and families the skills that they need to build healthy lifestyles and engage in educational opportunities from kindergarten throughout their life. Next slide, please.
I didn't know you talk so fast.
Oh, there you go.
I know.
They were supposed to all come. Sorry about that. Okay.
That's okay.
I was on a roll there. So just kind of want to give you an idea of how this particular Subpart D, Health for Health Services, is laid out. We have a purpose section, collaboration, communication with parents, child health status and care. We have an oral health practices, which is our small but mighty section. We have a section on child nutrition, child mental health and social and emotional well-being, family support services for health, nutrition, and mental health, and safety practices. Looking at this, the areas that got heavily moved around it or changed were the sections on child health status and care. Oral health practices is a new section for us. Child nutrition was minimized a little bit and streamlined, and a lot of work went into the child mental health and social emotional well-being section. Next slide.
And I will say, even though we're not offering these slides, we will have standardized slides that will be on ECLKC for everybody, but there's so many different iterations at this point, we just want to give folks one full set. Thanks, Marco.
So I think the health services section is a really nice example of us making the attempt within the office to really streamline the performance standards and to reduce redundant language and make it easier for people to follow and read through the standards. So overall, we updated the program performance standards related to health, oral health, nutrition, mental health, family support services as it relates to health service area and safety. The core health services from the previous performance standards were maintained, including the screening, ongoing care, and follow-up care, and we further strengthened the requirements with an emphasis on oral health and parent education and health issues. We updated the mental health requirements to reflect best practice, to ensure programs use mental health services to improve classroom management, and to support staff in effectively addressing challenging behaviors.
Marco, could you tell us how, because I think when people, when they hear you say we strengthen the requirements on oral health, people are going to say, ooh, what else do we have to do? So could you talk a little bit about how that was strengthened?
So one of the things that we did to strengthen that, there was a component of what we considered oral health related to toothbrushing, for example, that existed in the meals section. And it would get lost because the requirement was to do toothbrushing in alignment with meals.
Okay.
And I think that made it really, really difficult for some programs to do. So one of the things that we did, we clarified what the intent of that was. And it wasn't necessarily to just do it with meals, but to really engage in doing some oral health prevention kind of activities. So that's what we ended up doing with adding the new oral health practices section. Next slide. So the overall goal of the health section is to ensure programs provide high-quality health, oral health, mental health, and nutrition services that support each child's growth and school readiness. One thing to note, or one thing of interest, at least to me, was that in this section, as you're reading it, you're going to notice that there's reference to the Health Service Advisory Committee. And the previous standards, or the standards that are active until November 7th, that reference to the Health Service Advisory Committee was in the partnership section of the performance standards. Now it's been moved and put into the health section. Next slide. This section requires programs to collaborate and communicate with parents about their children's health in a linguistically and culturally appropriate manner, and to communicate with them about health needs and concerns in a timely manner. A lot of people think that that's new. It's not a new standard. We've had to do that before in the past. So this is the piece that's new, and this particular section now includes program requirements for advanced authorization, that's not the new part, from parents, and for sharing policies for health emergencies. That's the piece that's new in this particular section.
And Marco, and since you mentioned that, I think in a number of places we've gotten feedback from people saying, oh, you know, I can't believe you're requiring that now, and it is maybe a requirement that's been around for 30 years. But what we would say is that this is a tremendous opportunity, right? That it's to recognize things that maybe you haven't done historically, and not worry about what you didn't do in the past, but really use the opportunity to make sure that those practices are in place, and so that children are getting the high-quality services that we promise when we deliver Head Start and Early Head Start.
Exactly. Okay. Next slide, please. So this, to me, is one of the sections that was really reworked, and it was reworked for the better of the section, I guess, where we took an approach of when a child comes into the program, what is it that they go through, and what does the family go through to make sure that we figure out what the true needs of the child is at enrollment, right? So this section includes requirements for programs to determine children's source of care, to support parents and ensuring children are up to date for preventative and primary medical and oral health care, and to support parents to ensure children receive ongoing necessary care. It also requires programs to determine if children have health insurance and supports family in accepting health insurance if they do not.
So that's a new.
That piece is new. The family's piece is new. If the family doesn't have health insurance to support them in accessing health insurance is new. The other thing, too, that's also new is before we had a 90-day timeline as it relates to determining if a child has continuous accessible care, and now that's been shortened to 30 days. So that's a new requirement. It also includes requirements for extended follow-up care where appropriate and clarifies use of program funds for medical and oral health services. We used to get a considerable number of questions asking us to clarify that for programs if they were allowed to use program funds to pay for dental and medical care. Now we codified it in the performance standards.
Again, one would say we hope to be the last payer resort.
Right.
I mean, you would want to exhaust every other avenue, but in the event there's no other coverage.
Right.
Our funds, okay.
And not to just, and another note that's interesting about, or not interesting, but I think it's really good related to the use of funds, is that we also allow for the provision of diapers and formula, which was another question that we used to constantly get a lot of feedback from, where programs were constantly asking us if we were allowed to do this or not, and now it's in the standard.
Right. And so it's required, and we required it for a long time, but it wasn't in the actual, it wasn't explicitly in the regulations. We relied on another regulation, but we absolutely clarified now that is a requirement.
And I think from a program's perspective, I don't think programs are so much objecting to providing necessary materials that children needed, but I think it surprised people the cost of purchasing diapers. Mm-hmm. And I think that's when programs recoiled and said, do we have to pay for this? So I think they were more concerned about the budgetary, but I think we were clear from the get-go in Early Head Start. That's a necessary resource that a child needs to get through the day. Right. So that's a really great add.
And just to point out, we did get one question from you all related to the facilitation of fluoride supplements, and that falls under the extended follow-up care piece. The intent of that was not to make people nervous, or not to get people into this really strange piece of like, oh, I don't know what to do. It's to really make sure that we're determining the true needs of a child, and then once we do that, it's to figure out how we go about making sure those needs are met. As it relates to fluoride, is assessing and determining if the child lives in a community where fluoride is in the water system, and if not, to make sure that we have conversations with the dental homes and the oral health providers in the community to see what we need to do next to make sure that we get the fluoride supplements that are needed by children. And so that can take a variety of different forms. So some programs might have standing orders to provide fluoride, and some other programs might have some sort of other relationship with the oral health providers in their community to figure out what they need to do. So it's one of those opportunities to really engage the community, the oral health professionals, and also the HASAC to figure out how to meet that standard.
And Marco, it might be that not all the children who are enrolled in one program need fluoride supplements, but some do, right? Because exactly. You may have many different jurisdictions, and some may have fluoridated water. And I think many children who live in rural areas and are using well water may also benefit. So it really is something that a program kind of has to consciously do with regard to the children.
Exactly. Next slide, as we talked about fluoride. Our small but mighty section. It's literally only like 2 sentences long. So in this particular section, we require programs to promote effective oral health hygiene with daily toothbrushing. We've gotten a lot of pushback from people asking us why it's not two as opposed to one. The reason is because it's not, we weren't thinking about the overall day as much as what happens in the morning, at night kind of stuff. We were thinking about what a program can do while the child is in their space, in their program. So we were very comfortable with requiring the daily toothbrushing one time a day in the program. And then also we wanted to reduce the burden of programs having to engage in trying to do toothbrushing activities twice a day. This by no means if programs are already engaging in doing toothbrushing twice a day within their programs, we're not saying that you need to stop. You know, if they feel that that's the best practice for them, we continue to encourage that.
And if they, maybe it's a community with a high incidence of early childhood dental caries, and that, you know, the Health Services Advisory Committee says this is really important to do and Head Start, then that would be okay, right, Marco?
Exactly. Yeah. So with this particular standard, we feel that it was more direct and clear from the previous instruction, where we said that staff must promote effective dental hygiene among children in conjunction with meals, which is what we were talking about earlier. Next slide. So this is one of the sections that I think was reduced significantly, where a lot of stuff was taken out, and just the way it was located and how it was approached in the previous standards kind of took away from how easy it was to read as we have it now. So this section includes the nutrition service requirements, including how much food should be offered and the requirements for supporting breastfeeding. It also includes requirements about the use of funds, which I mentioned earlier. A new addition to this particular section is the making safe drinking water available to children during the program day, which did not exist in the current standard. Some of us kind of felt that it was under the facilitation piece, but it wasn't very explicit. During the NPRM, we got a lot of pushback from the community related to the idea that family-style meals was taken out of the standards. That was never the intent. What we wanted programs to do and engage in within the family-style meal concept was had moved over to the education. So all those pieces related to the idea of family-style meals is currently now in the education section. And then now to address the feedback that we got from the community, we just make sure that we reference family-style meals here and then redirect them to the education section.
And Marco, that we provide clarification, I think, in this body of regulations, that programs are required to do the things about family-style dining that have been linked to improved child outcomes around kind of social and emotional development, that it's a relaxed time, that adults are sitting with children. Right. But because we understand that in some jurisdictions it's been very challenging to have children serve themselves from serving bowls, while that's encouraged, it's no longer required.
Right. Okay. Next slide, please. So this is our new section. Well, it's not a new section. It's a section that got really expanded. Yeah. So the terminology in this section, the terminology was added to support programs in creating a culture that promotes positive mental health and social and emotional well-being, and to reduce the prejudice and discrimination around mental health services and improve parent and staff understanding of what mental health means for children. This terminology mirrors how the field of early childhood discusses mental health behavior. So we revised the section to include that programs must ensure that mental health consultants assist the program, staff, and parents, and clarified how programs must support a culture promoting children's mental health and social and emotional well-being, including targeting both internalized and externalized behaviors. We also clarified the qualifications of the mental health consultant in 1302.91. Where we know that it's difficult to assess mental health consultants to access mental health consultants in many locations, and therefore we only require knowledge and experience in working with young children if consultants with this knowledge and experience are available in the community. I think that was a big desire from the community, so we were just explicit in that particular section with that. We also reinstated the requirement from the previous regulation that a program must secure mental health consultation services on a schedule of sufficient and consistent frequency. And to help normalize the mental health consultant process and reduce prejudice and discrimination around the use of mental health consultants, we revised the paragraph A3 in this section to require programs to obtain parental consent for mental health consultant services when they enroll children in the program.
I agree, Marco. I think this really added a lot more clear expectations for the program services around mental health. You mentioned externalizing and internalizing. We hear a lot about concerns about children having very challenging behavior and the challenges that presents in a classroom setting, but we know that we need to be equally worried about children who, that's externalizing, right, challenging behavior, but we know we need to be equally worried about children who are quiet, who are withdrawn, who appear sad most of the time, who have difficulty interacting with adults. Often those children are viewed as good children, which is okay, but they may also be having suffering distress that, you know, is even greater than the child who's able to express it through a little, you know, hectic behavior.
Next slide. Speaking of hectic behavior. So the next slide. So the mental health consultants are integral to the steps outlined to limit suspension and eliminate expulsion in Head Start programs. And this is something that we've been hearing a lot lately. So I think what's interesting about this is this new language that we have codifies the long-standing practice to not expel children from Head Start programs. So we think this is definitely a really nice improvement to the standards. Next slide. This section includes the requirements that address health education and support services that programs must deliver to families. And I think this section does a really nice job of, before we had all these things scattered throughout the standard, it just kind of pulls it together nicely as it relates to health services. It also consolidated requirements from the previous rules to include parity and transparency, which is what I just said. And this section highlights the critical importance of parental health literacy, which was not present in the previous rule, and addresses home health and safety practices, which were also not present. In addition, we addressed the importance of negative health consequences associated with sugary beverages. Because a lot of kids drink a lot of soda, and it's actually tied really closely to BMIs. And anyways, we felt that was really, really important to highlight. We also addressed the need to help parents access health insurance for themselves and their families. This is one related to what we were doing up at the front end of the standard also. We mentioned it here. Next slide, please.
And I think CAPS and community action programs are so well suited in terms of supporting families and accessing health insurance.
Okay. So also one of the things that we always like to say is the process of the NPRM and getting information from the community in order to figure out how we move standards forward and make them better. We received a lot of public comment as it relates to this particular section, and we agreed with the public that we needed to revise 3 paragraphs within this section to better clarify the topics in which programs must offer to collaborate with parents, which include health and developmental consequences of tobacco and lead exposure, safe sleep, healthy eating, and negative health consequences of sugar-sweetened beverages, breastfeeding support and treatment options for parental mental health or substance abuse problems, and more broadly defined child mental health and social-emotional well-being. Next slide. And this is the last section in the health services section in Subpart D. So this is the largest section within the Subpart D as it relates to safety practices. This section includes the requirements for strong safety practices and procedures that will ensure the health and safety of all children. We moved away from prescribing extensive detail when it is unnecessary to maintain a high standard of safety. So instead, we allow programs flexibility to adjust their policies and procedures according to the most up-to-date information about how to keep children safe. And a good example of that is medication administration, for example. Before, we were very prescriptive about what you needed to do. Now we're not, and you will see it when you read it. And one of the things that we want programs to do is to really make sure that they align with whatever's happening in the local communities, what's happening in the state, what's happening with licensing, so that they're not being redundant or doing something that isn't normalizing the rest of the community, right? And finally, this section includes health and safety requirements for facilities, equipment, materials, background checks, safety training, safety practices, administrative safety procedures, and disaster preparedness plans. One of the biggest questions that we get as it relates to safety practices is at the front end of the standard, there's reference to consulting, caring for our children basics. We want to clarify that there's a misconception in the community between what caring for our children basics is and what caring for our children third edition is. We're not referencing to the 2.5-inch book of caring for our children third edition. We're talking about caring for our children basics, which is a minimum set of standards that were developed by ACF that are available on our website, and we can send that link with this if you need.
I think the other thing about the disaster preparedness plan, I have become to appreciate how important that is. And I just came back from Oklahoma, and we were talking about clearly there are folks in Louisiana, and we've got 40 families, 40,000 homes that are just gone. And one other gentleman said, well, we have to prepare for active shooting. So it really is incumbent upon programs to really take this seriously, and the whole issue about how do I contact people when these things occur, like getting in touch with parents or staff or so I know that you all have been involved for a long time in that effort, but it really is important.
And historically, our programs, and Head Start and Community Action, often are kind of a community planning hub or oasis, a place where people get food and comfort. And I'll never forget, hearing the stories of people who their first kind of contact from the outside world was their Head Start program, calling to check in, and they reported hearing from Head Start daily when they weren't hearing from anyone else, and often the programs are up and running before other kinds of organizations are accessible. So I agree, it's so important and such a key role, I think, that we don't always fully appreciate, because it's not sort of what we're funding, right? Directly to do, but really it is what the important thing is in the picture.
And can I just make one? So there was one question that was asked, and it was put in the category of health program services, and it actually doesn't exist, and it doesn't exist in this section. It's related to a performance standard that we deleted a performance standard related to PB requirements. And so I just wanted to clarify that in the previous standard, that reference to TB requirements was in the staff and wellness, the staff and volunteer health section. And so in the new standards under staff health and wellness, we do make a reference to I'm losing my train of thought, to communicable diseases, that's what I was trying to say. And so it's not that we're not saying you don't have to do it. That's not the intent of what we try to do with this particular standard. We just wanted to clean it up from what we previously had. And we really do think that you need to check with your state and your state licensing agency to see if, one, it's required. Two, you also need to find out what's happening in the community and what are the needs of the children and the families and the staff, and make a determination from there. One way to do that is to involve your HASAC to make sure and see if they're going to require TB screening or not. And then finally, you also, we didn't want to just limit it to TB, and I think that's what used to happen in the past. A lot of people just saw the requirement, and that's all that we're talking about as it relates to communicable diseases. There are a lot more communicable diseases than just TB, and we want to make sure that we're addressing that and not just being very limited. So that was the true intent of these standards.
Well, I don't see any questions, so you looked up, Marco. But, it's even helpful for, sitting here and just listening to you. I'm learning things that, maybe I sort of faintly knew, but now it's just, so I think it's, I don't know, what would Belinda say? You need to hear something 7 times before it sinks in. Right. So, it's helpful, and it's helpful to hear sort of the broader context and the thinking that went behind it. It makes it more meaningful, so, thank you. Okay, Amanda.
All right. So I'm delighted to have the opportunity to talk to colleagues in the Community Action Agency. I worked in a Head Start program for 10 years that was part of a Community Action Agency a long, long time ago. And I'm going to talk briefly about education and child development. Program Services, Subpart C, 1302 Subpart C. I'm going to give you just a brief overview of what's in this section. You'll definitely want to go back and reread it yourselves after I finish, because you'll be so excited to really, look at it. And I hope I'll talk a little about the rationale as well. You're doing an excellent job with those slides. Exactly when to flip them without me even saying that. All right, so the purpose and scope, I really encourage people to read the purpose, because I think it really is, well, for me, it's inspiring. I think it really is putting Head Start in its proper place as the leader of early childhood education in the United States. And it talks about how this set of regulations is raising the bar. I think that there are these 7 sections. We have purpose and scope, teaching in the learning environment, curricula, child screenings and assessment. Oh, it's important to know you can either say curricula as the plural for curricula, or you can say curriculums. Either is acceptable. It took me 3 or 4 years to figure that out, and so I just am giving away that for you. You don't have to go through that. The parent and family engagement in education and child development services, education and home-based, and tribal language preservation and revitalization. I'm going to talk about each one a little bit. Next slide. All right, she knew that, I didn't have to say. One big change about these regulations, you probably very likely noticed that we had what could have been called a little bit of an ad hoc set of regulations previously. Of course, Head Start was initially created as a program for children in their preschool time from first it was really 4-year-olds, and then it kind of was 3 to 5-year-olds, and then we, in 1969 or so added services to migrant families, which could be birth to 5, and then in about 1995-96 we added early Head Start for infants and toddlers, and each time we kind of injected some new regulations that we hoped were properly applicable, but it was a little rough, so we sometimes weren't clear about what was applicable to who. This new set of education standards is birth to 5, and we think it's pretty clear about applicability. Everything is applicable unless it specifically says this one is for infants and toddlers or this one is just for preschoolers. So teaching and learning practices, we have a lot more detail kind of around the performance expectations that we have for programs with regard to teaching and learning. In our training and technical assistance world, we've thrown around words like intentional teaching and scaffolding for a long time, at least a decade, and I think now we really try to explain what that would look like in the delivery of services. So when I say a strong focus on intentional, effective teaching, we connect that to the Head Start Early Learning Outcomes Framework, where we have the domains, subdomains, goals, indicators, and developmental progressions that teachers can use to understand where each child is, using their assessment information, and then plan for how they should individualize the curriculum to support that child's continued progress in that area. Those progressions actually show the developmental sequence by which most children acquire knowledge and skills, and they can really use that information in their planning. So now that's what we mean by intentional, effective teaching, that it's planful, and it's based on what we know about children's interests, their strengths, and their developmental needs. We talk about a content-rich curriculum and learning experiences, and many people have asked what content-rich means, and it means exciting to me. That's probably not the technical answer, but it means a place where, classrooms where there are, joyful learning opportunities, including some direct instruction, supports for children's interests and needs, creativity, curiosity, and critical thinking are taking place. There's repeated exposure over time and through multi-modalities so that children really acquire the skills and knowledge that they need, and their enthusiasm is preserved as well. And that you're using the data that we collect on each child to individualize, I already mentioned that, but also that we can
aggregate, we use that word a lot too, but we can combine data to learn about groups of children. We can think about, well, our children who go to Head Start for 2 years, do they look different as 4-year-olds if they went when they were 3 than the kids who just come in as 4-year-olds? And what does that mean about how we deliver the curriculum to children so that, or if, children in one part of our program, maybe one part of the program kids go for 3.5 hours a day, and in another option they're full day. Are there differences among those children? Or what can we learn, and how will that influence our teaching practices and the decisions we make about resources? And we have much more clear, I said explicit, but clear words, I think, requirements for home-based programs and the content of what happens during home-based programs. We kind of previously said, well, all the comprehensive services are applicable, but I think we give a lot more direction, again, about the outcomes and the performance expectations. Perfect. All right, and so
can I ask you, don't we even go a little bit further? I know that the T's are right there, where enhancing requirements around home base, but you curricula, but it is we're now requiring. Is that a new?
Yeah, we're going to.
So if you could mention that, because I think that is important.
Yeah, we have a slide about home-based, and one of the things that it emphasizes is the requirement for a research-based curriculum that's implemented. And home-based is a very unusual, special option because we're really working directly with the teacher, with the parent as the first teacher of the child, and so the curriculum is around working with the parent who then is teaching the child, but really importantly, our outcomes expectations for children are the same. We have the same expectations around progress and development for children enrolled in the home-based option as we do for all children in Head Start. So some of the things we describe or define in the standards are the requirement that there is a system of supervision and professional development, including a way to prioritize coaching for teachers. We think that all teachers need kind of ongoing supports and opportunity for reflection to be effective in their practice. This is one that I love, nurturing and responsive. I think in many ways in early childhood education, we sometimes feel like we are combating the push down of, academics from the older grades, but I like to talk about the bubble up of nurturing and responsive. It was something that came from infant and toddler practitioners about how rooted learning is in being in responsive relationships, and nurturing, which I do think of as the recognition of children's strengths and needs and responding to their interests in ways that are supportive of their development and are caring. That's bubbling up because now we were requiring that birth to 5 weeks. But of course, 36-month-old and 48-month-old children need that too. Adults need that too. So keep pushing that up. Let it bubble up. But we clearly in our regulations require it for birth to 5. There's, I can't say enough about the role of the Head Start Early Learning Outcomes Framework, which should have a pivotal role in the delivery of the Head Start education services. Also, one of, to me, the most exciting things to many of us about these new regulations, Head Start has long recognized learning through languages as an incredible strength for children. Many places in the country it can be treated like almost like a disability or a weakness, but 30% of our children are learning 2 languages, and we know everything we learn about brain science is telling us this is conferring an advantage. If you know 2 languages, you're less likely to get Alzheimer's when you're older. You have more cognitive flexibility. So I think when we say promoting bilingualism and biliteracy, that is exactly what we mean. We want to preserve that capacity is a strength for children using Head Start, making sure that they're acquiring English and recognizing that children who have a strong foundation in their home language are more successful in acquiring English literacy later. So we have specific requirements around the learning environment, again, linking it to the outcomes that we want for children, requirements for material and space. Huge conversations about nap and rest time. You can imagine that there were people who said, well, if you're increasing the dose, are you just doing it so children have time to sleep? We're going to be, paying extra money so children sleep. Well, in fact, we know from research as well as common sense, I just want to admit it, that many children need help learning to relax. It's a fundamental part of self-regulation. They often come to us tired, and exhausting them even more and then sending them home already tapped out after a long day to fall asleep too late and then not be able to sleep at night is not a good solution. Also, young children, all of us, again, resting gives us the time to consolidate what we've learned. We know this. Marco mentioned meals already and the recognition of the developmental importance for children in participating in kind of planned and relaxing meals with rich conversation. Routines are recognized as, you know, it's not that you just get through them, that we want people to have intention and make sure those continue to be high quality parts of the day, and we continue to recognize the need for physical activity. Again, that is a way that children often are, can contribute to their cognitive development as well as their physical health. We did not require a minimum amount of time for physical activity, and that is a fine example of the, we don't need to be that prescriptive. Programs need to figure that out, kind of in balance with the rest of their day, how long their day is, what their routine looks like, and to ensure that children get adequate, moderate to vigorous physical activity. We talk, well, I use curricula, but sometimes I say curriculum. But the curricula, the required components, it has to be inclusive of all the domains of the framework. It has to be per our statute, actually, and restated in our regs, developmentally, linguistically, and culturally appropriate, and as I said, comprehensive, including all of the domains. That's a high bar. Many programs may need to add a curriculum enhancement, which is separate curriculum in a particular domain if they find that children are not progressing in that area. They need to constantly be reviewing their data to understand children's progress, kind of in the context of the instructional practices, the materials, Fidelity. A lot of people are so curious about Fidelity. I know you'll probably want to go back and read more. You probably already have it open to this section. But Fidelity kind of means trueness. It means, did you use the curriculum the way the developers instructed you? So if it says you have to be a PhD researcher to use this curriculum, it's not a good fit for the Head Start classroom. Most of the curricula we use don't say anything like that, but it's just you make sure your teachers meet the kind of minimum qualifications, and then you see how much training do you need to do to implement the curriculum. Does the curriculum include all of the domains? Is it developmentally appropriate based on what you know about your children's development? Is it, you know, how can you adapt it, or is it adapted for the culture? I shouldn't use the word adapted, because has it been used with children from the backgrounds culturally and linguistically of the children in your program? And no curricula has been kind of tested with all children. But Fidelity, some programs have some curricula have a Fidelity measure you can use. An education manager can go in, or a teacher can use it. It's like almost like a checklist. Are we doing this? Are we doing this? Some don't, but an education manager or teacher can still understand a lot about whether the curriculum is being fully implemented by looking at the lesson plans, doing observations in the classroom, talking with the teacher. Before anybody replaced a curriculum because they were disappointed about its effectiveness, they would need to be able to talk about whether they're really implementing it with Fidelity or not.
Yeah, I was just going to say, this strikes me as such a management responsibility.
Yes.
You know, the planning it takes, making sure the teachers are successful.
Yeah.
And I just want to say that because it just kept screaming out, you know, we're talking about education, but more, this is a management team issue.
Yeah, there's a lot of this crosses over,
yeah.
And this requires, for teachers to be doing this high level kind of early childhood education, we need a lot of support, and a lot of this is related to program decisions around, like, you know, like the data. And I think one of the important things, again, about Fidelity is you're not looking at child assessment information in isolation. You're looking at it in the context of how are we implementing the curriculum.
What do we know about the professional development of the background of staff, the qualifications? What are we doing around professional development? What are the overall needs of children in this classroom? You know, are we meeting their mental health needs adequately so that they can really benefit from all of these things we're doing educationally? So all those kinds of things are part of it, and you're right, absolutely. There's a big management responsibility. An adaptation is mostly something that would be done. Often a tribe might want to do an adaptation with the curriculum because they are doing, for example, language immersion in their home or heritage or native language, and there is no curriculum. So in that case, it's not a common thing that you would do an adaptation. It's such a significant change to the curriculum that you would have to work with an education professional or a university to make sure that the changes would reasonably yield the same kind of outcomes that the unadapted curriculum.
So you just drew it as a sharp distinction between what you referred to before as a curriculum enhancement,
right?
And this is an adaptation, two very, very different things.
Yeah, because enhancement it's a separate curriculum that already has a research base, and you're just kind of plugging it in. But adaptation is really making significant changes to an existing,
like a skeletal change.
Yeah, right, exactly. Okay. So we have some new requirements around screening and assessment. We require that they be standardized, which means that they're delivered in a standard way, that you are following the instructions, that every child gets the same assessment, and that they be valid and reliable, so that you're screening or assessing what you think you are, and that different people could use the assessment and get similar results, or you could use it at slightly different times and get similar results, or different kinds of reliability. But that's what it is. And again, there's assessment for individualizing. And I already talked a lot about the use of assessment data in the aggregate or on the whole, and the characteristics of screening and assessment. We have some special things related to assessments for dual language learners, which I will talk about. And of course, I never miss the opportunity to say the purpose of screening is to identify children who need to be referred for additional evaluation. That's it. We don't use screening to individualize. It's a kind of quick, rough indicator of whether a child should be referred for additional evaluation. Assessment may also be used to refer a child. If a child passes a screening, but as you're doing ongoing assessment, they are lagging or not seeming to make progress as you would expect, you might want to, at that time, refer them for more evaluation. And the prohibitions on screening and assessment come straight from the Head Start Act. We're not allowed to rank children in order. We're not allowed to use a screening or assessment data to prevent a child from participating or getting services.
So we have a question. It's actually, I think, a crossover between some screening around health, but I think it gets to this kind of issue. Could you, Catherine, go up to the next one? So let's see, right there. Last week it was stated that a doctor marking on the physical that a developmental screening was completed was not sufficient, and we should complete one. Does this also eliminate the doctor marking vision and hearing as normal not being acceptable and we must do? So it's a little bit of kind of, I don't know if you could pull it apart. And
Marco and I have talked about this a lot. I think that this is an area where I think it's good that we have a performance expectation and we're less prescriptive than previously. What we care about is that an accurate screening has been completed for both developmental screening and vision and hearing. So if you know that a child got the same screening that you use in your program and the doctor kind of provides the results, I think that could be acceptable. I don't think just checking, developmental screening pass, yes. If I were a program director, that would not satisfy me because I don't know kind of how they did across on the whole screen. But if they send the screening and you see it and it works, that could be sufficient.
I think we feel the same way about hearing and vision. Is that right, Mark?
Exactly, yes. Okay. So, I mean, and one of the confusions, too, is related to if they're following a period review schedule, like the Bright Futures. There was a big lag between when the hearing screening is done and then when it has to, so it's done at like the newborn screening and then it's done again at 4 years old. There's a lot of development that happens and a lot of development that happens in the child's hearing.
A lot of ear infections.
A lot of ear infections, a lot of things that can impact that development. And what we've learned for a lot of our early Head Start programs who have been participating in our ECHO project, for example, who have been using OAE's hearing screening, we've identified a lot of children that have been referred and have engaged in the early intervention to get them the services that they needed, and the impact that it's had on their school readiness has been significant. So for those programs who have a nice hearing screening and a vision screening where they're periodically checking, we highly support that continues to happen. But I think the bottom line is, as Amanda mentioned, is if you are comfortable.
You have to be confident of the quality and accuracy of the screening. Sometimes we know a third party does all of your developmental screenings. You work with an agency and they come in and do them. That could be fine. We also know some jurisdictions that LEA kind of technically can't do this, but they require a particular screening, so you have to know the child's been screened using that instrument. So you locally kind of have to figure out how you're going to be confident. Oh, I know what I was also going to say. Another thing that we clarified is that you do the screening for, preschool age children at least every year. So even if they came in as a 3-year-old and you screened them, then they start at 4, people say, well, why do we have to screen them again? They were fine when they were 3. Well, they're older, and the gap may have arisen since then. And then this one's even probably less intuitive, but if a child already has an IEP or an IFSP, why should I screen them? They're already getting services. But what we recognized, and we consulted with experts in the field about this, is that a child could have a delay in expressive language and be getting language therapy, right? Well, they're not regularly checking the child's fine motor, and they might have looked fine when they first were evaluated, but again, a fine motor, as they develop, they may be lagging in that area, and it doesn't show until later. So we felt that it was important that you redo the screening even if the child's already got an IEP or IFSP. Now, if the child had a comprehensive evaluation 30 days ago, no, then you wouldn't have to, do a screening at that point.
I'm going to go back to, if we could, just before you go on, there was one about the meals, and I think that this is, the more we could keep saying it, if we could go up to the actual question. And we're just getting it right now. So you say they're recommended, but Amanda, exactly what are you looking for? Is it still recommended that everyone eat the same thing, or is it fine for teachers to eat something else so long as they're having conversations with the children? What are the recommendations about sitting with the children at mealtime? And I think this is absent, because people might be thinking, well, if we were monitoring, what would this is absent. What are we talking about as best practice?
But it is best practice for adults to be sitting with children, to be engaging with children. It's great if they can eat the same food. We have many children and adults who have dietary restrictions. I think in those cases, children can handle, people have different needs. This is, Mrs. Brown needs to eat this food. It shall not be a Big Mac and a large Coke while the children are drinking their milk and, green tea. And people are laughing here, which I enjoy, but in reality, we have seen things like that. So if the teacher is opting for something, else that's healthy, but because they can't eat what the children are eating, again, as Anne's saying, these are best practices. We are not going to go in and,
modeling food exploration, like it's
a lot of modeling.
It's a lot of modeling, and it takes how many times for a kid to engage in eating something new?
It takes like 11 times for kids to try something before they find out they
like it. If they see the adults also eat the same thing, they're more likely to engage in that behavior than if not.
Yeah, adults are really cool. To 4-year-old children, these teachers are their heroes. So I think thinking of kind of from that point of view can help teachers. But we've heard, we have many stories about the importance of this approach to dining for young children.
Okay, and there are a couple of other questions, but why don't you try to complete, and then we'll see if we can take those other questions and then go on to Kirsten.
Okay. So you can never use an evaluation, a screening, or an assessment to keep a child out of a program. Kirsten is mainly going to talk about parent and family engagement in education and child development. My one sentence that I like to say when I'm speaking about this is that parents are the most influential people in a child's life. The vast majority of child outcomes are tied to things about parents and the parent-child relationship, no matter how great we do in providing those services, still the child is going to always be the most reliant and learn the most from the parent. So to the extent we positively engage parents in children's education and we recognize them as experts in their own children, we are increasing our chances for success and really changing the trajectory of that child's life. So get those parents on board. Strengthening, I talked a little bit already about having a different kind of clear strength-based approach codified in our regulations. For dual language learners, we have more, we've always talked, we've said, thrown around, effective teaching practices. There's much more about what that means, and in conjunction with the early learning outcomes framework, I think teachers can do better. One of the reasons we struggle in America with dual language learning children is that if they don't understand the language of instruction, we don't try very hard to help them learn. And there are many non-language based things we can do to help children learn in other domains, including mathematics, science, social and emotional skills. Applying intention to those to make sure kids who are still learning English when we don't have someone who full-time speaks their language in the classroom is critical. We've got great language, I think. We really caused, probably took years off my colleague Sharon Union's life figuring out the language around screening and assessment for dual language learners, but we kind of have this tiered approach, and at the kind of most challenging here is when you have a speaker of an unusual language and there's no one else in the community who can help with any kind of interpretation. You still have to do your best to learn about that child's status through observation and whatever communication you can have with the parent and documentation so that you are increasingly learning about that child as he or she is acquiring English. Also that you make sure you learn enough of that child's words so that he will feel safe and secure and have his needs met in the classroom. You better know I want my mommy and where's the bathroom, I'm hungry, I have to pee. Programs can figure those words out in the interim. The coordinated approach to serving dual language learners in the management section, we talk about having a language plan so that, again, it's not a reactive, oh my gosh, I've got 6 different languages in my classroom, I'm the teacher and it's all on me and I don't know how to do this, but your program has a plan and an approach to language learning. We continue to have the requirement that more than 50% of the children in the classroom speak a language other than English. You must have someone in that classroom who speaks that language.
So one person watching said we totally skipped in 1302.33.5. And if after the formal evaluation described in paragraph A3, little I of the section, the local agency responsible for implementing IDA determines the child is not eligible for the early intervention of special education related services, the programs must. And this is, you didn't get, okay.
I'm going to get to it, but I will.
Well, you better get going.
I know, all right, you better get going. That's good, Anna. All right, so I've already talked about the need for linguistically and culturally responsive practices. I'll say, remember, culture is family and home culture. It does not always mean the country of origin, which we tend to think it does, but every family has a culture, and all those cultures should be represented and included in classrooms. Just having global babies from around the world on posters is not what we mean by culturally responsive, although it can be lovely. And really, again, I've said it over and over, having a strengths-based approach to comprehensive services for dual language learners.
We have for years in the Office of Head Start, again, promoted and believed in the importance of American Indian, Alaska Native Head Start and Early Head Start programs, providing language revitalization, preservation, and restoration through their programs. We have made that explicit in our regulations that is allowable, and in fact we think it's beneficial for children's development. And here's the one you've been waiting for. So our regulations are very different from our last ones with regard to children with disabilities or delays. We, as before, previously require, compliance with the Americans with Disabilities Act and the Individuals with Disabilities Education Act, so that's ADA and IDEA. We require the full inclusion of and supports for children with disabilities, including children with very significant disabilities. We newly talk about this category of children who have delays. So we know that during the recession, some states really changed their eligibility criteria for children. So in some states now you have to be 1.5 standard deviations behind the mean and below the mean in 2 areas of development. That is a significant amount of disability. So if you're 2 SDs below, you're way behind in one area, you might not be eligible for services. So what we have said in this set of regulations is that programs must do everything possible to meet the needs of children with a delay that is found not eligible under IDEA. And now I know in response to the NPRM, some people kind of panicked and said, we can't afford to get all those kids, services and bringing speech therapists. Well, 31 states allow Medicaid to be used for speech therapy or occupational therapy in many states. Sometimes children and families have other insurance that can be used. We do have programs that have decided to use their own program funds to bring in a speech therapist or another kind of therapist, maybe an itinerant special education teacher, for some number of hours a week to work with teachers around working with children who have delays. We understand there are, financial consequences, but this is one of those areas where programs need to be accurately assessing their community needs and figuring out how they can really meet the needs of children who are enrolled in their program. Tough decisions, but very important. This can also be true in communities where children can't get an evaluation. That is illegal, because under the law, children are entitled to an evaluation if the parent requests one. However, we do know that it's taking more, like the school year's over in some communities before the child gets an evaluation, so we are asking that in this circumstance, programs advocate very hard to get the evaluation and in the interim see if they could perhaps get services through Medicaid or another insurer.
So Amanda, I'm going to ask you to stop, okay? And while we transition to Kirsten, there was 2 quick questions that came up for Marco, and it was around, Marco, the TB, and I think we need to, if we go back to those questions.
Follow the state requirements.
So the question was, okay, so you're saying we can follow state requirements when it comes to TB? The answer is? Resounding yes. Okay.
Well, the state licensing agency, whatever is being required of the program.
Okay.
But they should still check with their Health Services Advisory Committee to make sure. Sometimes the community has a higher risk factor.
Okay. And why don't we go to Kirsten, and then there are other questions that have come in that will, if we have time in the end, okay? And I think these questions are great. It's just lots of dialogue needs to be had. But I don't, we started off saying the family is the most critical piece, and we don't want to short shrift the family.
Okay, well, it's great to be with everybody this afternoon. So let me give you some overview here related to families and family engagement and the standards. Critical to note that because Head Start is one of the original 2-generation programs, standards related to families and parents are going to be running throughout the entire body of regulations. So I am going to highlight a few of those for you here, but for those of you who have studied your standards, you know that there are standards related to governance and to eligibility and enrollment, and on and on and on. So I just want to point that out. And a couple of other key themes to keep in mind with regard to these standards, that they are outcomes-based, which is a bit of a shift. I'll talk about that more in a few minutes. And that there is, like all of the other standards, a focus on data and using data for continuous improvement. So this is a lot of words, and I'll give you a second to take a look. My intention here was to offer a little more flavor to what Amanda was talking about in Subpart C. Essentially what we've done is we've coalesced a lot of the standards related to the home-school connection, if you will. A lot of research that shows about the more we can help make that connection between the classroom or the learning environment and the home and family, the more impact we can have on children. So those standards reside here predominantly. They focus on, again, that role of the parent as a primary teacher and educator. And there's a number of them, ranging from accessible hours and creating an accessible opportunity for parents to visit a program environment through volunteering in a classroom. There are opportunities to engage in parent-teacher conferences 2 a year, as well as teacher home visits. One change with the teacher home visits relates to ensuring that one of those, if at all feasible, one of those home visits occurs at the beginning of the program year. A lot of programs do this already. There are also multiple mentions throughout the standards of the parent-staff communication requirements. And there are a couple of here that really revolve around teachers and parents communicating about children's routines, behaviors, successes, strengths, activities. There are also some requirements related to the importance of communicating around that screening that we were talking about. Not only the results of screening, but also the purposes behind screening. We have always had a standard about getting parents involved in the curricula of the program, but this one is a little bit different from what was in the previous regulations. It used to be that we invited parents to actually help us develop curriculum and help us think about instructional approaches. Given the shifting focus on the importance of the evidence base with regards to the curricular and the instruction, and it also didn't always, that standard was always a little bit difficult to implement. So there's a little shift here on ensuring that parents have an opportunity to give feedback on the instructional approach in the curricula, or ums, as Amanda has all educated us, and that is really, another sort of feedback and communication loop. Lastly, I just want to point out that the teacher efforts to conduct home visits in migrant seasonal Head Start, that's what the MSHS stands for down at the bottom, and that's not a new requirement, but it's kind of, we put it in boldface because there are particular challenges at times in conducting home visits, and so in migrant seasonal Head Start programs due to the changes or differences in the program year. But that it is still something that we would hope efforts would be made to do.
Kirsten, we have a question specifically related to that, the 2 home visits and the 2 parent-teacher conferences. And the person's saying, what if a child was newly enrolled shortly before or within the last 30 days of the program? Are we going to be held to 2 parent-teacher conferences and 2 home visits? And I think logically we would say, what would we say?
Well, I think one of the things I would do is I would try to think about the intent of what that regulation is about, right? Those regulations are really about communication, about getting feedback from the parents so you understand and can tailor the teaching and learning to that child in an appropriate way in whatever time you have, as well as to get to know the family and really get a sense for their needs. So I think, thinking about the intent of the standards and then making a program decision accordingly is probably a good way to think about that.
And I think this is where this is hard, I think, because the Head Start community, we typically say absolutely positively yes, absolutely positively no. And this is where there's the flexibility, sort of a little bit of good news, bad news. We're saying what's reasonable in that situation. And so we are entrusting programs that they're going to take in, as many factors as possible to make a reasonable decision. And in some cases, to be able to get into that home twice, even if it's 30 days, may be fantastic, particularly since the child's going to be returning. Or in some cases, it may not be realistic. But again, that really speaks to the flexibility.
I mean, that's great. And that's good advice for thinking about a lot of these questions. It is, isn't it?
Yep.
All right, let me give folks a little bit of an overview. We want to allow time for questions here too at the end, so I'll try to move quickly. Subpart E is called Family and Community Engagement Program Services. There are 4 sections here. A general overview, a focus on parent activities, some requirements related to the family partnership process and goal setting, and then a section on community partnerships and coordination with other early childhood programs. And the family engagement overview is really intended to kind of highlight those very broad brushstroke foundational pieces. So we're thinking about family engagement as not like a sort of one-time act, but it's the strategies that programs are employing should be integrated throughout program systems and services. And I think the regulations support that. That you'll see language throughout the regulations about the relationships we have with parents as collaborations, as partnerships, as a shared responsibility for children's learning. You'll see language like that in many places in the standards, and that was very intentional. We have also highlighted the importance of father engagement in this overview and bringing dads and father figures into the activities in a more explicit way. You'll see a lot of similar language like continuing from the previous standards about trusting and respectful relationships with families. And then there is a new highlight related to the teacher, home visitor, and family services coordination here. And essentially is, a lot of programs do a lot of this kind of coordination, but this is really saying, family engagement is really the business of everybody in the program because everyone has a role to play. And specifically, where we can really break down some silos amongst our teachers, home visitors, and family services staff, it's going to make for more quality services and a better experience for the family and for the child.
And can I comment here, when we think about, if programs think about implementation planning, I think the father engagement is a good example. Many programs have been way out on father engagement for many years. So it's not even an implementation issue, it's just validating what they're already doing. So, it's not, when we talk about the new stuff, many programs have already they're ahead of us. Yeah,
I think, the last time we had standards was in '98. So a lot of what these standards are doing is they're bringing the evidence base up to match actually our investments in training and technical assistance we've made over the past many years and highlighting those pieces of research. And they're also stating some of the obvious, like in this case, the father engagement. And just saying, of course, folks are doing it. It's really important to name dads. And so, we're just catching up with that in some respect. Also, it's also bringing things in alignment with our act, which was reauthorized in 2007. Next. Okay, here we have a section related to how we support that parent-child relationship around learning and development. Amanda touched on some of these things where we're really talking about what the benefits of bilingualism and biliteracy are with families. So not making assumptions that families have the information they need to support their child learning 2 languages, but trying to get more transparent about the benefits of that. Also not making assumptions around the reasons for attendance or not attendance, and really talking with families about really thinking about family engagement and attendance as a strategy for family engagement, essentially. I'm not really putting that well, but what I mean to say is that in the last many years, there's been an increasing focus on attendance as a critical engagement strategy. And so we look forward to supporting programs through our TA around new best practices for that. And then lastly, we have a requirement that's new around ensuring that parents have the opportunity to participate in a research-based parenting curriculum. And this would be similar in that knowing there's a sort of a lack of a culturally responsive, culturally specific parenting curriculum research base out there, or evidence base I should say, that programs can work with an expert to make significant adaptations if necessary. There's nothing in this requirement that doesn't say that programs can't partner with a community agency to do this work. In fact, one suggested best practice is to really start with a scan of what's happening in a community, think about the families that your program is serving, and think about where the matches are right off the bat. That isn't to say that, you know, your program might not be in a better position to offer something that really meets needs in a way that is not being met in the community. But generally, there are different ways to kind of get at this. Next. The Family Partnership Services is really building off of what was in the previous reg. It's a goal-setting process still. It's really meant to meet families where they are, to help assess families' strengths and interests and needs, and set goals with them. The difference, and to track those goals over time, make resource matches, referrals to partners in the community where it meets families' needs. But there is a difference here in that we're asking programs to ground their assessment and partnership process in the family engagement outcomes and the parent, family, and community engagement framework. So related to family well-being and the parent-child relationship, supporting families as learners, as well as supporting families as they engage in transitions with their children, supporting parent leadership, and also supporting parents' connections with each other. So those are sort of the outcome areas in a broad sort of frame, and I guarantee you that there's really nothing there that Head Start programs haven't been doing for 50 years already. So it's a new frame, and it helps us organize and target our work better. So I'm going to just, well, I think we're running low on time here, but the community partnership section is probably where I'll stop. I think we won't talk about the transitions or services to pregnant women today. But the community partnership section has been expanded to also include coordination with other programs. And if you think about it, you know, these regulations really reflect where our programs are now in time and space, and that we have, in order to do our work, we have to engage in partnerships that are based on the needs of the community, and we learn that from our community assessment, the needs of families, and we learn that through our family partnership and family assessment work, and that we also are existing in states and communities that are building and trying to defragmentize, if that's a word, early childhood at large. And so we also have regulations here that are really intended to help Head Start make those connections. Next slide. So very briefly, the community partnership standards kind of lay out the flexible requirements with regards to community partnerships. There are some new nods to those partnerships that where we ask programs to coordinate with homelessness liaisons through the local educational agencies. We're asking programs to think about their partnerships with domestic violence providers. There are a few other nods there. But rather than a list of providers, it's really supposed to be geared towards what programs are determining are the needs for, again, their program and community. Those partnerships are very much aligned with that. If you look at the next section in this slide has to do with some of those kind of bigger picture connections. And a memorandum of understanding with the local educational agencies has been a requirement since reauthorization in 2007, so programs have been busy working those for many years now. So that just kind of brings the standards up to date. The QRIS requirement is essentially a new requirement asking programs to participate in the quality rating and improvement system. Can you actually check the next slide? I just want to see if I included the... Okay, so we're not going to go to transitions today because we're not going to have time for that. But the QRIS has to do with the program must participate in its state or local QRIS if the QRIS accepts Head Start monitoring data to document quality indicators included in the state's tiered system. Somebody had asked a question, about what kind of monitoring data, and that is federal monitoring data, it's Head Start monitoring data. Also, a program must participate in its local QRS if the participation would not impact the program's ability to comply with the Head Start performance standards. And then also, the program has not provided OHS with a compelling reason not to comply with this requirement. So AIAN programs do not have to participate. This is a regulation along with the state educated data systems. That doesn't kick in until August 1st, 2017. And this is an area where we've gotten a lot of questions, and we will probably be coming out with a little bit more clarifying information. Good to check. We do have some resources online for people to learn more about QRIS states and sort of where they are. There are some states that are currently already accepting Head Start programs who have no non-compliances, or in some states who are using monitoring data as a way to kind of tier programs in. So, but those are, more states in the minority. So we recognize this is sort of an evolving requirement.
So should we transition to questions?
I think we should probably stop there.
We got the whole issue about home visits. That really sparked a couple of questions, Kirsten. And
the teacher-parent home visit?
Well, I think there are two questions on the table here. Do we have to do a home visit? Is one of the home visits have to be completed prior to the start of the school year? And then someone said if there are 2 home visits required, if I'm out there visiting the family as part of the application process, is that considered one of the 2 home visits?
So, the regulations and say that you should do including one home visit before the kind of beginning of program services, the commencement of the program, if
feasible.
And, I think, again...
And that's the only new thing. The home visits are not a new requirement.
Right. No,
just that before the program year is feasible.
And I think Kirsten's kind of reminder to be, thinking carefully about, well, what is the purpose of it? And that sort of has a application for the other question. The reason you're doing that early home visit is really to meet with the family on their own turf and to learn from them, to engage them as their child's most influential teacher, best expert, and advocate, and to give them the opportunity to tell you about their child. And so I think, it's important that you have that experience and information before the child starts participating in the program to the largest possible extent.
Well, even to the extent if the child recognizes when they're nervously going into that classroom for the first day, wow, that person was at a home, or
and they're kind of endorsed by their parent. This isn't a stranger. This is somebody who came to my house, and my
so to the extent possible,
right?
And I think you hear folks saying there are so many reasons why it is so much value added for the child and for the family and to the teacher.
And for the teacher, absolutely.
Here's an interesting one, and I'm not sure I quite can get it. If we are doing ongoing assessment, I think I get it. If we're doing ongoing assessment, for example, fine motor, that is so much further in depth than a screening in fine motor. So why does screening get much less information, and also doing ongoing assessment, thus getting more information on fine motor? And you could say that to every domain, right?
Right.
So I think
why
do the screening?
Why do the screening when we have ongoing assessment? I think it's a good question. I think that the reason is that many of our assessments show child progress. A screening really clearly tells you in a pretty fast way whether the child is doing things age typically or not, and are they kind of delayed in a way that suggests they might benefit from early intervention. So if that's its only purpose, where an assessment, you're right, you may get that information and you may use assessment data to refer a child, but it's hard to get that in that concise way across all the domains through looking at your assessment data. And even if a child has progressed a great deal, they really still may not be age typical such that they should you know, it's just, I think, a more efficient way to get that information.
We have 3 more questions, and I think let's try to get to them. I think one is on ratio, but let's start with this one. What is the definition of child development professional within the context of 1302.33 regarding the provision of IDA, Part B or Part C, provider referral guidance via the mental health professional consultant, or said guidance being provided by way of a child development professional?
I'm looking at it.
All right. So while you're looking at that, there was another one, if we could scroll down. Okay. Does it state in the new performance standards that developmental screenings must be done each year a child is in Head Start? So we're on the screening thing.
So what it says is within 45 days of the start of the program.
Mm-hmm.
So I mean,
so if you've got a program start date each year.
Right, exactly. So it's 45 days of that.
Right.
That's when you do it.
Right. So yes.
Can I, before you get into this, so you mentioned something that was really interesting when you were talking to Kirsten. It was on the father engagement piece and how programs have been doing it, and now we've codified it because it was in the Act and now it's in the standard. I always find it really interesting when we start getting questions and we start talking about, at least for the health services for me, is I think the fear is that programs think that they're going to have to be doing something that's completely different, right, or not doing something that they've been doing incredibly well. As it relates to the performance, as it relates to health services, we've been doing a phenomenal job at Head Start, and I think a lot of people always look to us as a, you know, how do you do this in your program? I mean, just look at the amount, the immunization rates, over 96%. You look at the number of kids who have continuous accessible care, also over the 95%. These are phenomenal. For a national program, these are phenomenal numbers. And when you see a program who starts off at 70-something% and then jumps up to 96% by the end of the year, we are doing something that is great. And if you're doing that, don't stop it. Like that's the thing that I kind of always want to say. It's like if we're doing this incredible work, like continue to do it, because it's nobody else is doing it. And I just kind of, you know, just kind of always like to say that we as a program, and even in our monitoring data as it relates to the health services, we've been doing a wonderful job.
Well, in regard to the earlier question about who a child development professional is, in this context of we're talking about assessment for individualization and who might benefit from a referral or need a referral for additional evaluation. So it could be the teacher. It would likely be an education manager or disability services manager that the teacher or the mental health coordinator or consultant who the teacher talks with and says, you know, this is my data, this is what I'm seeing with this child, and I'm concerned. Are you also? It could also be the parent. The parent could say, look, I'm really concerned. I know you say, you know, she's really coming far, but she didn't talk as much as my other kids or whatever. Any of those sources, but it's kind of that there's somebody who knows something about child development is saying, yes, we're concerned, and we are going to recommend to the parent that this child get an evaluation. So it really could be a staff person in the program who knows child development.
So someone asked about sort of recommendations for teacher-child ratio, and I just want to point out, if you are asking us questions, we all have our performance standards book open. We're looking at the citations because there's a newness to all of us, and we don't want to answer a question wrong. But I'm going to refer you to 1302.21, the section that says center-based option, and we have actually a table right in the performance standards that talks about the ratios for 5-year-olds, 3-year-olds, and under 3 years old. And in fact, it's on page 21 of the performance standards. So I want to direct you to that because it's going to be much more clear than I can be at this moment. And there was, go ahead, Chris.
Well, in some states, public school systems are exempt from participating in QRIS, but I don't know if that's true in all states. So the question
person
may be
QRIS just for child care entities outside of the public school system. So our LEAs required.
LEAs, to my knowledge, are not participating. Somebody can write a comment if I'm wrong, but it is for programs that are, you know, child care or subject to child care licensing. It was largely around trying to create a kind of a marketplace to provide incentives for quality improvement and to give parents information about the quality or the attributes of the different child care choices that they have. And we very much support the idea of Head Start participating in that to the extent it's reasonable and it offers some value added, you know, to the program and to the community.
I know it's 3:30. I know folks are going to start to drop off. I'm going to ask Denise to send us the questions that we were not able to get to. I do think that there were a couple that might have been HR related, and we will promise to address those when we do our webinar in November, because we're going to devote it totally on HR. We can't encourage you enough to embrace the standards, read them several times over. One read's not going to do it, and how you allocate your staff's time and governing body time and policy council time and really immersing themselves. No one's going to be an expert in everything, but I think for executive directors and Head Start directors, you have to have a reasonable knowledge regarding all of the standards, and if you're the health manager, not only do you really have to be expert on those health standards, you need to understand all this. We're talking about an integrated service delivery system, and I don't think anything can be read in isolation. And I think, Kirsten, you talked about the family stuff. While there is a really important section on family engagement, family is mentioned throughout. Same thing with dual language learners. So we want to thank everybody, and we look forward to our continuing work with our community action partners. And thanks Denise and her colleagues for inviting us.
Well, thank you, Ann, Kirsten, Amanda, and Marco for a great presentation, very comprehensive. Great questions that came in. People obviously have been reading and rereading and then rereading again. 7 times or 11 times? That's what you mean.
For me, it's 11. For most people, 7.
Please refer to the eClick website. Tremendous amount of information, additional presentations, just a ton of information. We will be getting a recording of this posted up on our site, but we do refer you to eClick. We'll have the most up-to-date information. Keep an eye out for those monthly updates that you're doing. I think that sounds fabulous to get you the most up-to-date information possible. We hopefully will have someone from the Office of Head Start join us at our winter conference that second week in January in Long Beach, California. I hope you'll come out for that. Keep an eye on our e-news for additional information that we will try to get out as quickly as possible when it comes out. And as Ann mentioned, I think when Head Start and Community Action, when it's working well, there's not a model out there that beats it. You talk about the parent engagement, the community partnerships, all of this stuff happens within a family. And even the disaster preparedness, that Community Action and Head Start, those community hubs, and we know in many parts of rural America, Community Action is the only site in town, especially those that serve low-income families and communities. So thank you for all you do. Thank you, Ann, and your team for being with us here today, and we will see you all soon. So take care.
Thank you.
Thank you.